Okay. Can you see my screen, everyone?
Along with your notes, Nuhu.
Okay.
On the screen.
Okay, I think this will be fine now.
That's better.
Okay, thank you so much. Okay, thank you so much, everyone, for being here, and thank you, Stu, for introducing me. So today, we are going to have some important discussion about hospital sanitation system and modeling fecal pathogen flow and health risk from urban hospital in Bangladesh, implication for sanitation decision making for healthcare settings in Dhaka. So for today's presentation, we will discuss about the introduction overview of this presentation, then methodology and stage to progress, which is an important of this at this stage, and also like thesis preparation and manuscript outline. For the hospital, sanitation facilities is an important indicator to achieve sustainable development goals. And when there is a sustainable development goals, there is important like two sustainable development goals can be achieved through improved wash in healthcare facilities. And when we talk about wash in healthcare facilities, there are usually a main 5 indicators like water, sanitation, waste management, hand hygiene, and environmental cleaning. For my research, actually, I focused mainly on water, sanitation, and waste management because hospital, these are linked with internal factor of cleaning of the hospital and environmental things, and also this also implement and also contribute the external environment, for example, like wastewater discharge, environmental contamination, other things. Since this is a modeling approach, so environment is very crucial at this stage of this presentation. So let's talk about the sanitation. So when we talk about the sanitation, there are multiple factors for healthcare facilities, particularly availability of the toilet is one of the biggest factor that actually need to consider when you talk about the sanitation facility, along with the functionality of the toilet and cleaning. And when you talk about the sanitation of the hospital healthcare facilities, this also include like JMP ladder, different JMP ladder, like improve, basic, limited, or no service. And toilet to users ratio is also another important factor that actually influence the quality and functionality of these things. So availability of the toilet has been assisted in many studies, but most of the studies has been assisted in Bangladesh, particularly in peri-urban area, not in the main big mega city hospitals. And also like because the mega city hospitals has a very overcrowded patients and caregivers attendant in the hospital, so the rush is really high, and that's why it's important to actually assess the toilet users ratio and functionality. And when we talk about the JMP ladder and functionality, there are a different ladder of the cleanliness aspect and the functionality and the service ladder as well from GMP. So recently we also conducted one study in Dhaka city, but during the COVID, the study was conducted during the COVID, but we still found that one toilet is used by about 60 users, which is really high. But during that time, we only covered about 20% of the toilet. So that's why we thought that we need to add this type of improve the quality of this surveillance from the hospital toilet cleanliness and functionalities. At the same time, environmental contamination is also very common. Hospital in low and middle income countries contributes very frequently the emerging infectious diseases, which is crucial that usually children and adults usually impact with the environmental contamination. Also, as you know, that hospital wastewater discharge hazardous chemicals, microorganisms, and pharmaceuticals that also contributed with other hospital wastewater and industrial wastewater as well. For example, wastewater from industry and also community. These all actually come to the environment and contaminate the soil, environment, and other things. So that's why it's important to actually quantify the load of the hospital wastewater discharge and how this is actually contributing the wastewater like human health and environment. As recently, we also published one manuscript, and we have conducted a study on hospital wastewater discharge, and we found that significant high amount of SARS-CoV-2 and indicator pathogens prevalence in hospitals in Dhaka city. At the same time, we also find similar pathogens in the environment adjacent to the hospital. So there is a strong correlation of the pathogen contamination from the hospital to the community. We also did the system modeling based on the environmental contamination from the septic tank area in the community. And based on these modeling, we will do our modeling on the hospital as well. So that's how we have actually built our research question and also objective. So our research question would be what was the status of hospital sanitation facilities and wastewater management in different hospitals in Dhaka city, feasibility of modeling fecal pathogen from flow from the hospital to neighboring community and the health risks in urban Bangladesh, how the flows of the pathogen can be modeled using understanding and also the understanding the health risks in the neighboring community. And specific objective follows similarly, like to assess the existing toilet facilities in hospitals within Dhaka city, identifying gaps and deficiencies in the sanitation service and for the improvements of the system, to assess the fecal sludge management and wastewater discharge mechanism of hospital in Dhaka city, and determine the future requirements for hospital wastewater management and treatment based on the findings. And finally, to develop, apply, and validate the system modeling approach to inform hospital sanitation infrastructure and also management and decision making, evaluate the public health impacts. So these are the methodology, and we will talk about mainly 3 points for my research. First of all, sanitation facility, latrine user functionality and the cleanliness, then on fecal sludge management and wastewater treatment and management, and also finally the modeling phase. So in stage 1 of my presentation, we have detailed discuss about the modeling, but here we will not go very detailed, but definitely we will show the progress of the modeling here. For fecal sludge, we work on systematic review to understand what are the existing literature and work have done in wastewater treatment, particularly for the low and middle income countries. During the results section, I will also share this with you as well. So, and in the modeling, we have collected additional data to build the model. We will not discuss, due to the lack of time, we will not going to discuss all this result in detail. Let's talk with the methodology, how approach of our data collection and selection. So we conducted a cross-sectional study, which is a mixed method study conducted between July to December 2022 in 10 government hospitals and 3 private hospitals. And based on some certain criteria, particularly in 2, we have selected hospitals from both North City Corporation and South City Corporation, hospitals with old building, hospital built before 2000 and after 2000, and also all 3 types of hospitals we have included for this study, like private hospital, government hospital. Then we also conducted within the government hospital, we have also selected general hospital, specialist hospital, and medical college and hospitals. So we also have a very robust and very ethical approval from a different organization, since it's a very conducting hospital studies little bit sensitive because of breaching of data. So first of all, we have presented this study to the Director General Health Service, and we have obtained their written approval to conduct this study. We also have our approval from our local organization, ICDDRB, for ethical clearance to conduct this study. At the same time, UTS, Human Research Ethics Committee, also provide the approval for this. At the same time, we have also obtained written informed consent, or also photo consent from all the respondents we interviewed for different levels. We kept the confidentiality of all the hospitals and the name of other respondents during presentation and during dissemination as well. So let's come to the data collection, what type of data we have collected. So first of all, availability and the functionality. So when we talk about the availability, we focused on the like privacy and functionality and of the toilets. So we use the toilet pan, whether toilet pan or commode or functional or not, latrine door, whether functional or not, what type of whether the toilet is used as a toilet or toilet is used as storeroom or other purpose, and whether there is availability of the toilet or not, or availability of the water during our spot check. So these are considered the functional and not functional. I will discuss in the results section as well. When we discuss about the cleanliness, we use two type of like data collection method. One is observed structure observation with different parameters like cleanliness of the pan or commode, cleanliness of floor and walls, smell of the feces, and presence of fly, insects, solid waste. So these combining actually defined as a functional like clean toilet or non-clean toilet. We also collected data, the perceived or feelings of the data collector. So they stayed there for about 15 to 20 minutes for the data collection and how they feel about their cleanliness. So we have four this data like perceived cleanliness tool. For example, like not dirty at all is very clean and dry toilet. Little dirty is it's still dry, but there is a spot or there is little solid dirt on it. Very dirty is usable, but is extremely dirty, and not usable is broken or other things. And these also have been actually implemented for recent, like the studies conducted in Kampala municipalities. And another important and challenging work was the number of patients for all hospitals. So we have collected information number of patients in all wards. So we approached each ward and we talked with the nurses and we collected the data of the how many patients admitted or appeared during the day of data collection, number of caregivers, so reported by staff nurse that average number of caregivers with the patient today came, number of healthcare professionals present during the day or overall healthcare professional present in that particular ward or healthcare facilities, and also number of support staff. So these combining we define as a toilet users in hospitals. And you can see that the queue of the hospital is in the outpatients is really high. So and the second picture here you can see it's an outpatient door as well. And also in the third picture you can see the inpatient door. There are over when there is outbreak or there are some epidemics happen in Bangladesh. So usually extra bed actually placed. So although the hospitals are based on some defined bed number, but it's not true all the time because increased number of bed is very common in Bangladesh. Let's talk about the sanitation and wastewater and fecal sludge management. So we also observe all the septic tank ABR present or any treatment plant present in the hospital to treat. And we also observe whether it's functional or non-functional. And whether there is any broken things or not, we are noted down to define that. And in the left side of the picture, you can see that we also measured the sanitation drainage map. So how the drainage is actually connected with the environment and whether they have actually safely managed or not safely managed, like whether feces are directly connected to the drain or there is any treatment option. For example, in the right side of the picture, you can see that there is these are the hospital premises and the red dotted non-continuous is the drainage system around the hospital, and in this ABR it's present in this hospital and it's discharging a green mean. It's like treating very well. But at the same time, you can say that at this here in the backside of the hospital there is a bypass drainage which is actually not connected with any ABR system. So all the feces and everything is going through this. So this hospital is not like a safely managed hospital. Is like partially safely managed hospital we define. So we will discuss in the results section about like these results as well. Additionally, for the modeling purpose, we use wastewater discharge amount, like how many wastewater discharge per hour. So we estimated the daily discharge, hourly wastewater discharge rate using a stopwatch, and also predefined volume of water for each how much time it takes to actually refill this bucket. At the same time, we collected information on the water extraction volume from each hospital, and we have noted down, and this will be used during the modeling as well. In the modeling, we will also use the enteric disease prevalence from these hospitals, particularly general hospitals and medical college and hospitals. So how many monthly enteric disease actually come to the hospital, and what frequency are there, and if there is any specific pathogen actually contributing that enteric disease or not. So that was the quantitative data we have collected. It was now let's talk about the qualitative one. When you talk about the qualitative results, here we usually focus mainly on sanitation and fecal sludge management and waste management. A total of 39 qualitative interviews were conducted from these 13 hospitals. So first of all, we focused on key informant interview with PWD engineer, like public work department engineers under the Ministry of Housing and Public Works, and he is the key person who actually deal with the hospital infrastructure structure, septic tank area design and all the design of the hospital infrastructure. Ward master is like both deal with the engineer and also the cleaner and also like hospital directors. So he usually manages the hospital cleaning, supervise the nurses as well sometime, and also he is actually supervising the all cleaning stuff as well. We also conducted 10 key informant interview with the cleaners of 10 hospitals, so to understand what are the challenges they face and whether they're actually very comfortable to cleaning that, what are the challenges and what should be the way forward to overcome those cleaning. At the same time, we also conducted 10 key informant interview with the patient's caregiver, because we thought that it's important to actually understand their role and how they feel about the cleaning, and because the cleaner always actually blame the patients that they are not able to actually use the toilet, and that's the reason why the toilets are getting more dirtier most of the time. So that's why we also included them for the interviews, quality interviews. And let's talk about the data analysis. So this is the descriptive statistics we have used to for the toilet functionality cleaning, and also like frequency of the toilet we have mentioned in different hospitals. Prevalence ratio are also estimated using the different parameters like old versus newly constructed hospital sanitation facilities difference. Also, if there is any like a difference between a medical college versus specialized hospitals, difference using the Poisson, and also frequency of a hospital that provide a basic, limited, and unimproved sanitation service. We also like correlate this with the JMP data as well. So next on the quality data analysis plan, we have used the grounded theory research to actually from the beginning of the study and to revise the data collection based on the information we have collected. And after we collected the information on recording, we have actually transcribed all the recording in the Bengali transcript, and then we translated into English, and we coded them into different themes, and we analyzed the themes, and then actually we collected those themes to actually make a summary for the presentation. So just very briefly, I'm going to show you the themes of how we have actually grouped this. For example, to engineers key informant interview, we ask about these themes. For example, wastewater, septic tank, and pitch lighting functionality, the mechanism of like discharge, repair and maintenance, design of the septic tank area, latrine, whether there is any like recommendation for what is the funding issues. So we ask about very structural issue with the key informant interview. At the same time, for the ward master and cleaner, we actually ask the same question about hospital wastewater treatment, hospital septic tank functionality, mainly like toilet cleaning and functionality issues. We have asked very in depth with the ward master and cleaner. And the similar things we cross-check with the caregivers, whether the statement of ward master and cleaners are actually valid or not, how they feel about the cleaning, and what should be the way forward. So that's the method section. Now the one of the important section. So you can see that it was a very in-depth and very robust work. And we are able to do structure observation about 2,618 toilets. And in this graph, you can see the hospital H1 to H10 is the government hospital, and hospital P1 and P2 is the private hospitals. And highest number of toilets we found in 430 toilets in hospital 1, followed by hospital 9 is 379. Least number of toilets we found 43 in hospital 8, and in private hospital you can see it's 61 and 121 hospitals. So we are really lucky that we are able to observe more than like about 85% of the toilets, which is a great achievement, I think. And those toilets were not actually observed, like 15%, most of them are locked and under construction, and also some were not permitted with the observed during the data collection. And this is the overall toilet to users ratio. So overall, we have found that 31 user used one toilet overall. So it is not segregated results. And here you can see that the bar actually showing this yellow bar is all users, followed by number of toilets here and number of beds. So we didn't use any bed analysis, because we found that analyzing the toilet users ratio through bed is not actually very appropriate for this hospital, because the users is really diverse and different quality. And you can see that overall users to toilet users ratio is really high on an average for most of the hospital, and it's above the Bangladesh government standard. And here we also did some segregated analysis with the staff to toilet ratio. So you can see that staff to toilet ratio is not very much high. It's also like very low compared to the national standard, or reported by the water rate recent report here. So you can see it's ranges from 4 to 16 in government hospital and 13 to 28 in private hospital. But interestingly, you can see the toilet to users ratio is very high in patients' toilet. Particularly, you can see it's more than about 250 users use one toilet in hospital 6, and hospital 9 is 164 users use one toilet. So there is a disproportion between staff toilet ratio versus patients to toilet ratio. So cleanliness functionality is 70% toilets we found that functional, that make the privacy, water is available, and also and the functionality is consistent about across the government hospital. So, and also most important reasons for a non-functional toilet is a broken door we found. So water is very available in most of the toilet, but broken door is one of the important challenges we found here. Only 35% toilet we found clean. So 65% toilets are not clean. So it is also very striking. And most of the during the informal interview, they say the repeated use and high use of the toilet is one of the important reasons for this unclean toilet. And when we discuss about the perceived toilet users ratio, like toilet cleanliness, that how the field worker or data collectors think about the toilet cleaning. So they also found that only the blue bar here is the clean toilet, or not dirty toilet, but rest of them are actually, they feel somehow it's dirty. And when we group this not dirty at all or little dirty toilet together, it's still 61% toilets are actually not clean, according to the perceived or feeling of the data collectors. And let's talk about the regression analysis with the difference between different parameters of the hospital on functionality and cleanliness. So private hospital is more cleaner, we found, compared to the government hospital. Then hospitals constructed before 2002 before 2000 were more actually not functional compared to the hospital built 2000 after 2000. Staff toilet is significantly more cleaner compared to the patient toilet. You can understand the high users ratio is also an important factor here. We don't find any changes between inpatient and outpatients cleanliness and functionality, but we found that sex segregated toilet are more cleaner. Like if the toilet is actually male or female, those toilet are dedicatedly male or female. Those are more cleaner compared to the mixed use toilet. One of the striking thing is also that only 18 toilets we found with MHM facilities, which is really very important to actually address in the future. And less than 1% hospital has toilets for disabled or person with limited mobility. So these two are actually at least missing from these mega hospitals in Dhaka cities. And for the wastewater discharge and treatment, you can see that 4 hospitals in our study hospital didn't have any type of wastewater treatment and water treatment, even septic tank or ABR. So they usually go directly to the environment. 3 hospitals has partial wastewater treatment, like it's like broken or somehow it's bypassing partially. And also like 4 hospital actually having 5 hospital having somehow ABR or septic tank. 1 hospital in private hospital, you can see there's P3, they have chemical ETPs. So that's the 1 hospital they have like wastewater treatment. And we will incorporate everything, most of the results in this Excel model for the system modeling. So we will use the QMRA wiki to estimate the pathogen load and in different parameters. We will also use our data with existing things. So in this Excel file, you can see all the hospitals level from hospital 1 to hospital 10, and we will input all the information here. And after that, we will understand. So this is the end product. So this is what only I'm just trying to show you what should be the structure we will use in the modeling session. So now let's talk about the like quality results. So you can see cleaner actually clearly mentioned that lack of cleaning stuff is very common, also mentioned by the ward master as well. So they are actually multitasking for these things. So they usually involve in patient caring, patient cleaning, food serving as well. So they have also been very much frustrated with the job opportunity sometimes because they have to do a lot of things. And little or no knowledge on wastewater discharge, so cleaner don't have that much things. So one of the cleaner actually mentioned there is a shortage of staff in the hospital, making it hard for the cleaners to manage it, all the work, especially in the afternoon and night. 5 people work in the morning, while only 2 more come in the afternoon and night. It is not enough to do all the tasks, and the bathroom is not being cleaned as effectively as it should be. If more staff were employed, then it would be easier for the cleaners to manage the workload and ensure all the areas of the hospital are truly clean. So this is the quote from one of the cleaner. So also PWD engineer, it was very difficult, first of all, to actually get the access because they don't want to talk on record because they are from the different ministry. Hospital do not, and he claimed that hospital do not maintain the cleanliness and this is their responsibility. Old hospital needs to be demolished because it's FSM, fecal/slash management is difficult to manage here. And he also, I strongly believe that high patient user is also one of the factor to actually this mismanagement in the hospital. Similar things we also get from the patients, that we also patients also agreed that patients have limited knowledge how to use the like high commode or how to use the sanitation. They are not careful. Toilet is not open for all the time, they have mentioned, so it's locked most of the time. Cleaning frequency is not that much good and not frequent, so that's why many times the cleaners are actually not available when they actually need. So there is one of the quote, important quote from the caregiver, that there are no specific bin for the menstrual pad disposal. As a result, some people just drop some dispose this sanitary napkin and other materials open near the commons, and some other flushes them into the toilet. When we see the menstrual waste in the toilet, we do not use the toilet until the next day cleaner cleans the toilet. We go to another toilet nearest toilet. If there were separate bins for the hospital for the disposal of the menstrual waste, the bathroom would have been dirty. So this is one of the important quote from the caregiver's perspective. So that's the results, like both quantitative update from the things, and very briefly, as I mentioned earlier about the systematic review and the manuscript plan. So this is the systematic review we have submitted in Environmental International. So the objective of the systematic review was to actually understand the efficacy of the hospital wastewater treatment plant in low and middle income countries, and also like availability as well. And in the results, you can see that the wastewater treatment results studies have been increases since 2000 to 2020 is increasing, and most of the studies has been conducted in Asia. And also like we have also found that very small amount of studies has been actually conducted according to the national standard of the effluent, so they don't follow the national standard of effluent discharge. Manuscript 2 would be on the quantitative data, so we also have been draft this and shared with the senior author for their review the results. So this study, like toilet functionality, cleanliness status, and toilet to users ratio, particularly on the JMP ladder, we will use the quantitative results. So this has been actually, we have planned to publish this in PMC Public Health or PLOS One. So we are happy to share that this has been like submitted for UNC Water and Health Conference, American Society of Tropical Medicine, and IWA, and IWA already accepted this abstract. Manuscript 3 also challenges the cleanliness and maintenance of the functioning, the cleanliness of the toilet in healthcare facilities. So these are like qualitative data we have collected for different interviewee and in different stages of hospitals. So we also do this analysis. We have completed the analysis already, so we'll dump the manuscript very soon, and also similar manuscript journal actually focus for this. Number 4 manuscript would be like sanitation, like ABR or septic tank functionality or wastewater treatment approaches. So this will be also like a mixed method study considering the wastewater discharge mechanism, spot checks, and functioning of the ABR and septic tank, and also a qualitative interview related to the wastewater discharge. So target journal would be the International Journal of Hygiene and Environmental Health, and we plan to share this abstract to some IWA like conferences. And these are the final manuscript on the modeling. So like this will be the final product in the future. Yeah. So I would like to thank the field team who actually dedicatedly work here. So all of them are fresh graduate. So now they have actually well trained on qualitative, quantitative, and other data management as well. So I'm really proud of this team. They have worked really hard. I also thank like Bill and Melinda Gates Foundation, Bangladesh government, and Director General of Health for their support, as well as ICDW support to conduct this study and use the facilities things. Also, like I'd like to thank my supervisors and my colleagues at UTS who supported me throughout. Thank you very much for your patience hearing. Over to Stu.
Well, thank you so much, Nuhu. That's a tour de force, to be sure. So now we can open up for questions, particularly prioritizing those people who are not part of the panel. Who would like to ask a question or make a comment? Simon, right here in the room.
Okay, well done, Nuhu. That was a great presentation and such detailed data, and really useful and important data to have out there. I just had a question about some of your qualitative results. You said there was a bit of a difference in access to toilets between staff and caregivers patients. I was wondering within your qualitative results whether you noticed there was any differences between different types of patients, whether there was inequalities in terms of access between, say, richer patients and poorer patients, and whether there was any evidence of fee for access to toilets or better conditions or facilities within the hospital.
Yeah, thank you, Simon. I think this is like we have more data to analyze according like segregated analysis. Particularly, we have data on cabin, like personal cabin data as well. We have collected separately and who actually use and how the toilet function. There is difference. If you are able to like stay in the cabin, then definitely the wash facilities really very improved. You will have private toilet. You will have like clean toilet at the same soap and all the washing material and everything. But for the general wards in Bangladesh, particularly low and middle income country and lower middle income country usually go to this type of hospital because private hospital are really like booming in Bangladesh. So that's why I would say, except for the cabin facility or the ICU or CCU, most of the patients in these hospitals are low or low middle income status. Yeah. Okay,
great. So there's probably a bit more detail to come out in the qualitative analysis, it seems, but that's really useful. Thank you.
Yeah, for qualitative analysis, we didn't actually focus on this type of users perspective rather than functionality and the cleanliness and the reasons, because it's very already is a lot of data here. We didn't focus on like patient care or patient facility. I understand that's another things, but not in the qualitative interview, Simon. Yeah.
Thank you.
Yeah, thank you.
Other questions or comments? No? Okay, well, in that case...
No, okay, thank you, Stuart. No, this is an excellent presentation. I think that you did a great job. Even like that, working with the government hospital is not an easy task. I think that Professor Tanvir will agree with me. So like that, this is really an interesting and innovative work, I think, because nobody basically had attention to this work, especially in healthcare facilities, because it's always like kept like separated from the other national piece of work. So like this need a great attention. At the same time, even during the COVID-19, we have found that how challenges it was to manage the COVID and non-COVID hospitals. So I think that this study can like help to get an important policy implication at the national level. However, I have just one question, like in many government hospitals, like did you find any responsible person, especially in the hospital? Because most of the administrators are physicians. So even then, like, is there any person responsible who look after these wash issues at the same time related to like supplies and other things managed by someone on a regular basis, or something they manage it differently?
Yeah, thank you for this nice question. Yeah, there are some, because it depends on also with the type of directors and his actually perception about the wash and sanitation. So in some hospital, there is wash committee and very active, and they have very up-to-date information. For example, if I say Kurmitola General Hospital, Means Hospital, they have very well-defined like committee for this management. But in some hospital, they don't have this type of committee because they are having difficulties with managing patient. They don't have the staff for doing this. Yeah. So, but if the committee is very strong, then there is a possibility of improve this type of sanitation facilities.
And just to this is a supplementary question. You have mentioned about the two hospitals, like the neuro hospital and pulmonary hospital. These are very unique hospital, government hospital at the national level. I think that other than these two hospitals, most of the hospital are very differently managed, and it's not all managed. So like, did you find any reason for that? Like why these differences between these hospitals?
Yeah, I would say infrastructure is one of the biggest challenge, that these are newly built infrastructure with very well planned. Maybe they assess the users to patients ratio, and Means Hospital, they have very limited number of patients, so they are able to manage that very well. But in Kurmitola General Hospital, I think the Brigadier General, the army person, they have managed it very, very well, and they have regular meetings with the cleaners and all the ladders. But in other hospitals, number one, infrastructure is not very good, because the building structure is not for the hospital, but they build the hospital over there. And also the director is not keen to actually focus on managing wash. So I think two important factors. One is like infrastructural design for sanitation facilities or wash improvement. And number two is how the directors of the hospital committee feels about importance of the wash improvement in his hospital. Yeah.
And my third last question to you, like that, and you have shown that in private and government hospital, the differences in wash quality as well as services. Do you think that infrastructure is an issue, or the patient load is the most important issue? Because in government hospital, that it's overloaded. Even many patient, they don't have bed, even they keep it in the floor. So do you think this is an issue, and how do you have any thought that how can we solve this?
So we have actually data to actually segregate and analyze according to the ward or according to the patient's load as well, to see whether patient load is correlated to the cleanliness or not. So we didn't analyze the data yet, but I think yes, it is actually correlated based on the key informant interview. And I agree with you that users ratio is one of the biggest factor along with these two that I have mentioned. Yeah. But way forward, I think if we want to develop any new building, then we have to incorporate this. With the existing building, it's really difficult to actually improve, with the standard that the Bangladesh government or the development sector need according to the need. Yeah.
Yeah, I want to start.
Well, thanks. Simon, you've
got applauding.
Oh, applauding. Okay, that's good. Appropriate. Any other questions or comments?
So, shall I ask now or later?
Well, if it's a general,
this is Tanvir.
The general audience might find useful, Tanvir, then by all means ask away.
Okay, because like you mentioned that the panels will ask questions later or something like that, or that doesn't matter.
We'll get a chance to ask Nuhu detailed questions, but if it's a general question that might be of interest to the general audience, then by all means, please ask away.
Okay. So maybe I'll ask one or two now, maybe some later. I have a very fundamental question here. I'm sorry, my internet connection here is a little bit sketchy. Just let me know when I'm dropping off.
We can hear you.
Yeah, sure. Thank you. One is that the topic here is the wastewater management, specifically the fecal, the domestics, the sewage part, sewage, whatever we call it, that part of the hospital wastewater. Now, the reason why a hospital is different from any other institutions, like a school or any other community centers or whatever, the fundamental part is the same, because you have limited number of toilets serving a lot of people. But where the hospital is different from any other institutions is it deals with some infectious waste, and the waste management itself has a very big bearing on the quality or maybe sometimes the quantity of the wastewater generated. And here in this the plan or the study plan, I haven't seen any information on the waste management side of the healthcare facility. my feeling is that that might have some important implications on the quality of the wastewater generated, which is going to be treated somewhere in the hospital premises, or some of the outcomes. The pathogens and etc. that you'll study down the line, or the fecal flows that you'll study down the line, it might have implications on how
Or
I think we lost him mid-sentence.
I think we've lost you, Tanvir. So maybe we'll, in the interest of time, we might just ask Nuhu just to briefly respond for the benefit of the broad audience, and then we can come back to this question when we have the panel. So Nuhu, would you like to make a short comment for the visitors before we move to panel?
Yes, Stu. Yeah, I think we agree on this, Dr. Tanvir's comment, because what happened, we also initially there are lots of study has been conducted on like solid waste management. So that's why that's a different part. And we agree that solid waste management, needles, syringe, these are also very important factors that can be contributing in the Suez network, drainage, everything. But for this PhD research, we cannot actually handle the solid one because it's too much for me. But definitely this is contributing a lot with the wastewater. So no study you can see that focus on the liquid waste management, because although Bangladesh government
I was disconnected.
Sorry, Tanvir, we will come back to this in the panel session. Nuhu is just giving a brief response for the broader audience.
Okay. Yes, like JICA, like Bangladesh government work with the JICA, and they actually use the solid waste management. So I know this is not actually well managed, but there are some system. But for the liquid waste management, there is no regulation until 2019 or 20. I think government now actually putting some regulations, but they don't have any laboratory capacity. They don't have any understanding of how to collect this. So ICDRB and UTS actually built. From 2017, we have built this capacity on how to collect these infections, water, how to treat it, and how to test it for the future, like to actually show the data. So health perspective, actually wastewater is more vulnerable for the environment. We are not considering only the internal side of the hospital, rather than like how it's exposing the children and neighboring the community and other things. So that's why we focus on the wastewater from the hospital, not the solid waste. Yeah.
Right. Thanks, Nuhu. Well, we've just a couple of minutes, so we probably should let our broader audience go on time. So I'd like to thank everyone for their keen interest in this topic, and wish you a good afternoon. And we'll keep Juliet and Tim and Alison and Tanvir on the line for the next part of the process. So thanks, everyone. Simon has left the room, but he appears to be still logged on, but he's not.
Yeah, I can remove him.
Should we stay on leave, Juliet?
So Mahbub, you can jump off. Yeah, but thank you for coming. That was great to see you.
Okay, thank you.
Thanks
so
for joining,
much.
Mahbub. Take care.
Yeah, thank you so much. See you.
Yeah, see you next
Bye.
time. Bye.
Bye. Bye.
Great. Well, thanks everyone. So what we might do for this session is just go around the panel and just any observations or further questions, including further exploration of the question from Tanvir. But I might, Alison, without wanting to put you on the spot, I was just wondering if you had just some initial thoughts, and we'll have a chance to supplement that. We'll go around a few times before we so that we can make sure that you've got every question answered and every comment made.
Sure, I can do. And thank you, Nuhu, for the presentation. It's really great to see this work being done in hospital settings and urban settings, which I think are hugely neglected area, and having done a bit of work in these kind of facilities elsewhere outside Bangladesh. Yeah, it was really fascinating for me to see the work that you're doing, and I think it's highly valuable. I did have a few questions. I've got quite a few, but I might start off with kind of similar points to what emerged in the previous discussion. And then maybe sort of one bigger picture question. I just also wanted to go back to the point that Tanvir was making. Just, I'm not, by no means sort of fully on top of the types of services that these hospitals provide and the different types of wards and things that they're that are available, and also, I guess, the infrastructure across hospital. But from my experience elsewhere, for the wastewater treatment section, I think, the waste that's collected from sanitation facilities is probably one of the largest loads, but there's also different types of liquid waste that are entering the system, and that can be through like laboratory waste and improper disposal of waste from laboratories, also in sluice rooms where cleaning fluids, pharmaceuticals, liquid pharmaceuticals, etc., can be entering these systems, and that can have various sort of implications on the effectiveness of treatment, and also implications for then what's entering the environment. These systems might be effective for removing certain microorganisms, but not so much for some of the other potentially harmful things, pharmaceuticals, etc., that are entering the waste. So I just wanted you to touch on what your thoughts are in terms of the different types of waste that might be entering these systems, and if that emerged, and what proportion or what some of the kind of critical implications you think might be for that. So that's one. I'll do three. The second one was similar to the previous question, looking at kind of the ratios of toilets to patients and users. I thought it was really great how you defined users, because obviously there are really diverse users, and often it's just taken from bed ratio or patient ratio. So I thought that was really good. I am conscious that different wards might have different ratios and different needs. And when you were talking from your qualitative interviews, I'd be interested to hear if anything emerged kind of on the use of those toilets from an infection prevention and control perspective. So if I just give an example, often when there might be like a outbreak of a particular fecal oral disease in a hospital, they'll cohort patients, put them in small groups together, and require sanitation facilities that are frequently cleaned, etc. So I just wondered if you could talk to it all, if anyone commented on that kind of more clinical infection prevention control aspect of toilet availability, use, functionality, and cleanliness, not just kind of general, sort of a more kind of macro look at the hospital as a whole. And then the last one, which maybe we can come back to later, and we didn't delve into deeply, but I'm just quite interested, and some of the specificity on, you talk a little bit about the impacts to kind of public health, and you talked about health in general in communities and a bit of the environment. I just wonder if you could talk to more about how you're, I guess, defining these. So is it really largely a human health perspective of the implications that you're looking at for this wastewater treatment? Are there any kind of further measures and implications you're looking at more broadly at the environment and where this waste is entering, where this waste is going after it's leaving hospitals, and just if and sort of how you're defining those parameters in that second part of your thesis, which I know we didn't delve into in detail, but I'm just kind of looking at that sort of consistency of framing and definition across the project. Thanks.
Thanks, Alison. Excellent question. Yeah, I know, like, these are some burning questions this will come. So implications. So as I earlier mentioned that we have conducted a systematic review on wastewater discharge and like what type of wastewater treatment plant are over there in lower middle income countries. So that helped us to understand the standard of wastewater discharge, what type of wastewater treatment plant are over there in lower middle income countries, and pathogens discharge and quantification. So I understand these are the very compound and complex wastewater, including pathogen, blood, antibiotics, vial, and everything, like chemicals as well. So we also found that these complex and business owner like wastewater treatment industry, actually, they are also aware of this, and that's why they have actually planning for like advanced treatment technology for hospital, not like traditional things. But from our systematic review, we found that there is very few advanced treatment technology in the low and middle income country they use. So my impression on this like compound wastewater treatment is actually we are from the low and middle income countries perspective, we are far behind yet to actually achieve that goal of clean wastewater from the hospital. It's very difficult. Number one problem is with the structure. So what happened in the operation theater, the suction is sucking the blood with a lots of organisms and saliva, and everything is going directly to the drain. And the knowledge of the cleaner is not there, because the body fluid or the vomiting actually stored in the beneath the bed, it's down to the like toilet pan. So there is no separate or segregated wastewater discharge or like body fluid discharge or incinerator in the hospital, in most of the hospital. But particularly, I'd say that there is no knowledge of the like low grade worker, particularly cleaners, ward masters. They don't have this. We also interviewed the cleaners, and they don't use the PPE for actually during the cleaning, even though they put the mask when cleaning the septic tank or ABR. We also talked about that. We have the data. So there is a huge like gap on this. And also important thing is there is no research on wastewater quality. So only the engineers maybe actually did some pre-post analysis, but there is no true research of what type of quality of wastewater and what type of wastewater treatment plant actually needed for the implication of the health. That's still missing. So for the second question on like infection control within the hospital, so we didn't present the like sanitation hygiene data. We have also collected the information on basin, availability of the soap, and also like surface cleaning of the hospital. And also I'd say like sex segregated hospital toilets for the newborn care, and also toilets for the operation theaters, cabins. We have all the data, but if I share you very little, like all the bathing place and the basin were mostly functional, but less than 1 or 2% place has soap. So because these are very big and large hospitals, so government cannot afford the soap. So the problem is with this, like the soap cannot be kept over there, because people actually take the soap and they don't keep it, because it's like a public place. It's not like everyone actually using that soap and they take it away. So that's the biggest challenge. So we also like recommend about like using some infection control measure, like low-cost hand washing agent for this hospital. We have the technology, we have the like innovative solution from ICDRB. So we will also propose that in a separate way. And number 3 on like wastewater discharge and how it is actually connecting with the community. So usually what happened with the wastewater, it is discharged to the either with the wastewater treatment plant with the Dhaka City Corporation. Like there is only one wastewater treatment plant in Dhaka City, and 20% of the wastewater treated over there. Rest of the wastewater actually mixing to the environment, and when it's flooding, everything actually contaminated. So we have like previous study like Cenipath exposure pathogen study, and also like pathogen flow study, like we combinedly together we actually published in journals, and we have seen that pathogen contamination actually vary due to the seasonality, because when it's rain, it's actually increase or decrease. When it's actually near to the toilets of the community toilets, it's actually very high contamination. Surface water is also similarly contaminated. So actually hospital, community, industry is very much merged together and involve contaminating that. So there is no particular wastewater treatment plant. So that's why we are now planning to actually on-site wastewater treatment plant for hospital. So if we can actually at least save the hospital to actually discharge the contaminated water, then we can actually manage some, reduce some of the contamination. But still, it's not environment is very difficult to clean because there are other aspects of contamination like industry, communities also not very much clean. Alison, over to you.
Thanks. Thanks, Nuhu. So, Alison, did you want to ask a supplementary question, or shall we just keep going around and you can think on it before your next turn?
Yeah, I might think of a few specific ones. Yeah, sort of delve a little bit deeper, but I'll see what else emerges, and then whether we go different directions or we keep we start narrowing down to a particular few issues. So I won't take all the time and pass to others, but I definitely have some more.
We've got plenty of time. So, but Tanvir, I might come back to you because I think you might have missed the response from Nuhu about the question that you had about solid waste. So just in case, I wonder, Nuhu, did you want to comment on that again? And then Tanvir, you can ask any follow-up questions. But perhaps Nuhu first, or Tanvir, did you want to clarify what you did hear and what you didn't hear?
Yeah, I actually heard Nuhu's response. So, I mean, I'm not sure I asked the question in total, but I partly asked the question, but I got the full answer, of course. But now here comes, I have a few other questions. Now, as per what I understand is that solid waste management, of course, you're not investigating those and the effectiveness of that because it's kind of out of the scope of your work, which is fine. But as per my understanding, the wastewater from a healthcare facility, you are targeting, you're talking about the total wastewater, but your investigation is more focused on the fecal wastewater because you're going into latrines, looking at their effectiveness, how it's washed or not washed, other people involved, etc. But a huge part of the wastewater from healthcare facilities comes from in the form of, let's say, liquid, as you mentioned, coming from laboratories and other infectious material handling, etc. Not necessarily these are all flushed down the toilet. These go directly into storm drains and open drains, coming without any treatment. Now, if we look at the liquid wastewater coming out from the hospital, you might find that that is bypassed through your ABR system and going directly to your drains, which goes to the environment and to the community if there is not a specific waste treatment plant installed for that. Now, that is a very important source of infectious disease transmission, as per my understanding. The fecal wastewater, of course, is an important source of disease transmission, but this one as well. Now, if you are focusing on the septic tank or the ABR, I'm assuming that the infectious diseases from the laboratories are not going to the septic tanks, going to the environment directly. Yeah. So, and that infectious disease or the whatever pathogens, the prevalence of that is a function of the IPC healthcare, whatever what do you call it, infection prevention measures inside the hospital. How good is it? Now, if you are actually targeting the total wastewater, you won't be able to account that part of the wastewater if you do not take into account the IPC measures inside the hospital. And you'll find that that information might be delayed or missing because of it. Now, how do you actually plan to accommodate that? Because eventually you're going to do pathogen flows. And the pathogen is coming from both the fecal and also the other part. So the fecal is accounted for. You looking at hospital inside, cleaning, etc. from the latrines. So that one is accounted for. But when you are actually going through that part of the liquid wastewater, which is flushed directly, and you try to find out the causes for that, you'll have to look inside the hospital and see its IPC. So my first, of course, this huge part of gray water that actually discharged from the hospital. How will you be able to link that or correlate that to other elements if IPC measures data or something like that is not collected?
Yeah.
Thank you.
Yeah. Thank you. Yeah. So, just to clarify one thing, so you can see like 4 hospitals, they don't have any type of wastewater treatment facility, even ABR or septic. And it means those hospitals actually discharging everything through drain, including chemicals and liquids and everything. So, for example, those hospitals you can mark as non-safely managed, and everything is going to discharge. Two hospital has actually partially or broken ABR or septic tank. Somehow it's maybe actually like protecting, like preventing the solid waste to going to the environment, but definitely like pathogens are actually going, and 5 hospitals have some sort of wastewater treatment process. And from our recent study, we found that ABR and septic tank is not working due to the overuse, and definitely wastewater is more complex here. So that's why I think if there is no wastewater treatment plan, for example, dedicated treatment plan for chemical or like compound wastewater, then it will not be a good solution for preventing the environment. So that's my one point, that we consider all the hospital, those hospitals don't have any wastewater treatment plant at the same, because septic tank and ABR are never clean. We also asked about the cleaning and other frequency, and they said that last 10 years we never cleaned this. It means somehow it's not working, or it's somehow they are bypassing somehow with this thing. So that's why so these wastewaters should be treated as like infectious wastewater. Even if it's the gray water, it also be a like needs to be treated infectious water, because all the like if it is like bathing water, the infectious like disease patient actually bathing. So that gray water actually is not like gray water, it's actually infectious water. That like cleaning, like laundry services providing all the diarrhea disease, all the infectious disease and blood with the cloth. They're also like washing this through the detergent. So those are not like community gray water. It should be infectious. So my point of view is to actually treat the whole wastewater rather than only treating the ABR or septic tank discharge water. So that's my another point. But there is also challenge that how we also estimated the volume. And for example, for treating the wastewater in Kurmitola General Hospital might not be feasible, because millions of liters actually discharging every day. So that's why like this liquid segregation is very important. So for this thesis, we did not use like black water or gray water, but we actually define this as liquid waste. Any liquid dumping through anywhere is actually considered as an infectious liquid waste from hospital. So that's what we are actually planning for. And if until and unless we cannot segregate this, like body fluid needs to be segregated and needs to sterilize separately. Bedding, like laundry needs to be actually treated, and laundry water needs to chlorinate before discharging. Was like this, like fecal sludge needs to actually and other infectious needs to actually treated through the advanced treatment plan, and that needs to be actually treated separately. So this is how actually.
Can I just jump in? Sorry, I just want to try and clarify. I think what both Alison and Tanvir are asking, which is about since the other liquid waste that comes into the grey water is in addition to anything that's in the black water. What you've presented so far is a lot of research that's about the black water. I think what both are interested to understand is questions that you asked in the hospital to understand more about the details of the grey water and these other waste streams, and what do we know about them, since we need to know that as well as about from the toilets.
Yeah, for
yes, actually,
yeah,
that's the point. You're talking about the recommendations, but I'm actually asking, like, do you have any plans down the line to correlate the infectious, let's say, disease transmission to the existing practices of the hospital regarding to IPC? Because if you have that plan down the line, if you want to correlate, then you need to collect data on the what sort of chlorination and laundry, what they do and do not do inside the hospital. That information needs to be collected. If you really want to correlate, like the reason for any infection I'm not talking about the treatment. You're talking about the recommendations that these things need to be done. But are you collecting the data for those IPC, chlorination, blah, blah, these measures inside the hospital so that you can correlate that data later on with the outcome of the hospital?
Yeah, I got it. Yeah, but unfortunately, I think we don't collect any information regarding the like practice of using these products or like discharging of this specific liquid from different places, and also like how they manage it within the hospital and how it's discharging. We didn't collect this information through the qualitative interview or the quantitative interview. Yeah, we don't like that. This could be one of the limitations of this study. Yeah.
Okay. And I have a very small question side by side that is that so this was the main question, of course. One is that when you use the JMP indicators in WASH in healthcare facilities, so there are actually 5 categories: water, sanitation, hygiene, and the other one is waste management and environmental cleaning. So these 2 columns definitely will be absent here in your, so you might want to highlight that. So the waste management and environmental cleaning. And in the JMP indicator, it is not called unimproved, it's called no service for healthcare facilities. So you might want to correct that as well.
Sure.
It's called no service instead of unimproved.
Sure.
The title is a bit long. See if you can shorten it a bit. And if anything, yeah. So far, I have these questions. Maybe some questions might arise. I'll want to give the other panelists opportunity.
Thank you very much. Yeah.
Thanks, Tanvir. And Alison, you look like you had a follow-up question there.
Yeah, I did. It's just a comment, just to reiterate, I guess, emphasize what we were trying to draw out before. And I might, differ a little bit from Tanvir here in some senses, but at least from my experience, you're not really sure what's entering what at what point in the system. So the source control is often really limited in hospital settings. It's dependent on available infrastructure. What something's built for is not necessarily what it's used for. It might differ ward to ward. It might differ how clinical staff understand what should be poured down a sink or into a toilet versus other staff. So just that my question was sort of centered around that, was that source control component. And I think it is important. So sometimes it might enter a different drainage, but also just to be clear on kind of if you unpack or can make any comment on some of the plumbing and where which waste is entering, where there are on-site treatment available, what is actually entering that system. It might not just be waste from toilets. So I just wanted to kind of re-emphasize that point. And part of that is, I know in your systematic review, you've talked about kind of antimicrobial resistance, and you do talk about antimicrobial resistant bacteria, which are often much higher in hospital settings. You talk about the genes, but there's also the risks of the compounds entering the system that wastewater treatment can be less effective at removing. So it's just sort of an important in that bigger picture when, for your second part of your thesis, when you're looking holistically, is just understanding what kinds of wastes are entering these specific systems and the implications that might have. And while you haven't collected that data, in this first part, I just think it's important to acknowledge that that's something that's that is unique to hospital settings that might differ from community settings and other settings. So I just wanted to kind of wind out that point, but just give some explanation.
Just to add with Alison, that we have also like previous study on like exposure. So there are a couple of studies that are published based on like hospital exposure pathways, so how much children are exposed and how much their probability of being diseased. So we have that data, but definitely like that's not specific to the hospital. But during the modeling, we will be a little bit cautious on that. It's a very in-depth data collection, and it's a huge effort in 6 months, and time was really short. So we also plan to actually collect environmental catchment areas disease prevalence, but I'm not sure how much we can cope with that in during my writing. So that's one limitation we have to accept. But it was really like.
Absolutely, but it could be a future research grant, hint, hint, nudge, nudge. But I think that area is sort of not very well explored. So anyhow,
Great, thanks, Alison. Well, we might turn to Tim, if I can go to you next, and then Juliet. So Tim, do you have thoughts, comments, questions?
Yeah, no, thanks, Stu, and Nuhu, well done on the presentation. There's a huge amount of work that sits behind all this, so congratulations for what you've managed to achieve to date. It was really great to hear it all presented in a sort of synthesized, consolidated way. So thank you. I guess I have a question about your research questions and the extent to which they mirror the work that you've done and how that's represented across the different papers. And so I guess my observation is that at the moment you've got 3 research questions. The first one is about the status of sanitation and wastewater management in different hospitals in Dhaka. And then the next 2 around modelling. So I'd be interested in your view on how your second and third research question differ, because when I sort of read them now, they seem quite similar. So it'd be good to get a sense from you whether there is a clear difference, or whether potentially you could consolidate that into a single question. And I guess secondly, in terms of your papers that you've outlined to date, and certainly the analysis that you've presented to date, the bulk of it is in that first question around the status of hospital sanitation facilities and wastewater management. So I guess, again, a question about those research questions. You've got 2 on modelling and 1 on the status. Do you think that's the right kind of balance, given where much of your work is? And I granted that the modelling still to come, and so that may actually be a massive piece of work. But I guess, yeah, it'd be good to get your reflections on whether you think these research questions, as they're currently articulated, are how you see the work and being proportionate to where the work is directed across the thesis as a whole, or whether you think that you might potentially evolve those research questions as your thesis kind of takes shape.
Yeah, Tim, thank you so much. I think this is an important question, and yeah, I think this will be a single research question on system modeling and the outcome of the system modeling. So as you know that we already built this like hypothetical model, and I worked with Jay last year as well on this, and like I just took the feasibility one because I'm still not sure how this will actually provide the output of the results, because we worked together on the community-based system modeling last time. Also, I went to the Freya's paper as well, and we know that like adding this model with the existing model might be a little bit changed, but I'm not sure how much it will actually look like, how different it will. That's why I just keep the feasibility of like system modeling with this existing like output. But this can be one single things, and related to the like how this bulk of the information will be integrated. So there will be little bit addition to the existing community-led wastewater like system modeling that we have done, because the pathogen load could be different, and since we have more data on wastewater discharge and volume of wastewater, so I think that can be a proxy indicator to estimate the amount of wastewater discharge. At the same time, for all these 13 hospitals, we have the information about the pathogen discharge and also wastewater treatment plan. And I have seen that there are a couple of paper mentioned, if the hospital have the wastewater treatment plan, what should be the dose of wastewater like pathogen discharge versus those hospitals, those don't have any treatment plan, what should be the load of pathogen in the environment. So we can use those proxy indicator in the model, and that could be added with that as well. And every pathogen exposure will be integrated here from the previous literature, not from the empirical data.
Great, thanks, Nuhu. I guess, I mean, one follow-up comment, and apologies if I've mentioned this in supervision meetings in the past, but I like it because I heard Jamie Bartram mention it in a previous stage assessment relating to water and sanitation, and particularly around monitoring. And I guess it's just a comment or a suggestion to keep in the back of your mind as you're going forward. We're 8 years into the SDG era, so we're more than halfway through, and I know you've you've discussed aspects relating to monitoring and definitions and ladders. But I guess one suggestion is, as you move forward, is how can this work inform the next era of monitoring and indicators? Because I think, by the time you publish a lot of this stuff, there's going to be a lot of conversations about, well, what does all this look like as we sort of move from the SDGs into whatever comes next. And so I think that's a really good opportunity, because you're going into such great detail and there's really rich data and you're providing, really important insights, is how can that influence monitoring of Washington healthcare facilities, beyond 2030. So that's more of a comment than a question.
My impression, team, SDG indicator needs to change for big hospitals like this. So if you say one toilets for one hospital or one ward, and X number of patients, so these hospitals don't follow that rule. So one toilet used by 300 people. So although they are a functional toilet, improved toilet, but it's used by a huge number of people. So that definition needs to change. So that's my impression. So after we publish this one, I think there will be a segregation like tertiary level hospital, primary hospitals, and other hospital recommendation. But I understand this is only specific to one city. But if we can do similar type of study in different cities, large or big hospital, because researcher is scared of doing this type of work because they have to invest huge amount of time in the hospital, because structured observation of 3,000 hospital toilets are not found here. So that's why I think we need to replicate this type of study more in India, Pakistan, Sri Lanka, Nepal, this type of very highly populated area. Then we have to work on this ladder gradually. So that's my recommendation, would be to improve the JNP definitions.
Okay. Thanks, Nahu.
Thanks, Tim. So Juliet, any?
Great, thanks. And first of all, again, well done, Nuhu, for pulling that all together, and for the huge amount of work that you and the research team did, including under some semi-COVID times. So I thought I'd maybe focus in a very different area to what we've been discussing so far, and that's more around research methodology and the interview part. So you described in the presentation today the use of grounded theory to build up a picture from the interviews. But at the same time, you described that the interviews were quite structured. You were asking about very specific things. It wasn't like there were wide open-ended questions, which is more what you might usually then use grounded theory from. And so I guess I'm interested to hear you talk about the methods of analysis of qualitative data, and whether or not you think drawing on any different types of frameworks. And I know, we have touched on this in supervision around motivations or behaviors of cleaners, or of these different interviewee types, of what might be a way to make sure that you've got a level of rigor to that analysis, and some form of theoretical basis for the methodology.
Yeah, I agree. Yeah, I agree, Juliet. Yeah, as I got 40 interviews, and one interview is about one hour interviews, so it took little time. And I agree that, so now the results is almost like synthesized according to the theme. And since, to be very honest, I'm a very quantitative researcher from the beginning of my life. So and I took more than 2 weeks with this UTS training on the qualitative research, to be very frank. But I think the results now, how we are actually designing, is like showing the story. But I definitely work on that to actually read whether this can be actually fit with any theory or not, and whether that can be actually replicated for the other studies or not. From my initial search, Juliet, from health research, there is no such type of interview, but there are community research, there are many theories people used, but not in the healthcare settings, people use any theories on them. But I'm happy to read more on this, because this is still, I could not actually cope with this qualitative interview, in-depth, everything. Yeah, it's still in analysis phase. Yeah.
Great, thank you.
Thanks. So, Alison, back to you. I think you had a few more questions, or maybe you thought of some more comments or questions.
Yeah, I'll just have one back to bigger picture, and that's just on kind of the ethical side of this work. And I know you talked about kind of de-identifying the hospitals and those people that participated. I just, wondered if you could comment on any of the other kind of general sensitivities around, drawing out some of this information, what the implications are for perhaps government versus private hospitals, when this kind of data can hit the media and the implications for trust and engagement in the health system. And just, if you could talk a bit more broadly about the work that you found and what you think some of the bigger sort of ethical and sensitivity related issues are, and how you might manage that.
Yeah, thanks, Alison. Yeah, this is a valid question. Since I'm also native here, so fecal contamination, usually we don't perceive as a very big threat for us because we live here. So to the hospital authorities or the director of health, I don't think they will also very much surprised with the data they have, because I shared very preliminary data with the water rate, and they said that this is fine. I understand, because there are lots of mismanagement here. So I think media will not take up this very. One of the things will be actually think that lateral not clean, like 65% or 65% toilets are dirty. So this will definitely take up by the media, but it will not be in a panic for the ministry, because usually they understand there is huge load of the patients and they are serving this huge amount of patient. And also from the key information interview, Alison, we also found that patients are also satisfied with this situation. Why? Because they think that they are getting this service free of cost. So how people will get more service with free of cost? So perception of the patient is also not that much. Expectation is not of that much that this is my like taxpayer money. So that's why, like, I don't think this is a very sensitive issue for Bangladesh, but definitely cleanliness would be like very sensitive issue for the ministry and everything, but all the media. Yeah, that's my initial impression, but globally, this is very like not a good scenario for Bangladesh, particularly city of Dhaka. It doesn't sound good for the global media as well, yeah.
And just one follow-up question on that. Do you see any implications? Just an extended question. So for the second part, when you're doing some of the pathogen flows, if sometimes the sort of science, in my experience, the science-based underpinning of how some of this work might correlate to health outcomes, for example, like outbreaks in NICUs, for example, lots of babies dying, or a huge amount of post-operative infection rates, etc. Sometimes the correlation, it's just sort of, is not necessarily there, but the kind of implications can arise. So it's interesting to hear your perspective on that. And I just wondered the implication of that social norm and acceptability of current conditions, what implications you think that might have for kind of action based upon your findings. And if you have any thoughts on that.
I think one of the biggest achievement we have through this project, that we have shared little data with the government, and we have submitted one research proposal on hospital wastewater treatment plan in 2021, based on our preliminary findings, and government actually liked that, and they admit that yes, we need to implement the hospital advanced wastewater treatment plan. So we have got the award from the government, and we are planning to implement wastewater treatment plan as a pilot scale to how actually is treating the wastewater in one government hospital. So that's, and government actually is very keen to actually treat the environment. After the COVID, you know that environmental contamination is getting more like serious issues for the government, and for the SDG, this is also very much important priority for them to like safely manage sanitation and reduce the discharge of the contamination in the environment. So that point of view, I think this study has a good implication on like preventing wastewater. Like number one, we got the information that hospital is actually discharging contaminated wastewater. This one is, and we have to manage it. So this is one information we actually proven through this study. And follow up, we need to install on-site wastewater treatment plant. So these two is actually the thing. On the latrine infrastructure and based on the engineers interview, we found that they think that existing policy of hospital management is not actually effective. So they need to change the policy of infrastructure particularly. So for example, they build one hospital based on X amount of patient, but the patient flow dramatically increased. So they never actually calculated that like 50 years or 100 years projection with the toilet infrastructure or building infrastructure. So they said actually they are middlemen, they are not at the ministry level, but they perceive that this needs to be increased, and there are lots of like analysis before you build a hospital or toilet hospital. So I think once we publish this data on the building structure, infrastructure improvement and toilet to users ratio, and we publish the segregated results on out facility patients versus inpatient facilities, what are the different, then I think they will be a little bit sensitized. So this is what I perceive could be another implication. But there will be more, I don't want to highlight that, but I think there will be more implication on different environmental aspect as well, yeah.
Thanks, Alison. Tanvir, did you have more comments or thoughts?
No, not exactly. Just one clarification. Nuhu, have you consulted this national strategy for WASH in healthcare facilities in a framework for action, which is published by the Ministry of Health, Family Welfare, Bangladesh?
I went through that document. But I didn't find any like correlation with my work, because I found that particularly my focus in on wastewater discharge and this ABR and septic tank. So all the document from the Bangladesh government usually focused on mostly infection control within the hospital, but very limited on the like how it's contaminating the environment. And I also found one of the biggest challenge with the Bangladesh government is the pathogen concentration detection. These are not actually focused in any document, because I know there is a lack of capacity over there. But I'm not sure which document you are referring to, but I usually reviewed almost all the healthcare facilities, WASH and healthcare facilities documents. Yeah. Okay. But so, feel free to actually over there, like go through that. Yeah.
Yeah, so this one is, of course, you mentioned, as you mentioned, this is a more of a strategic document. It has some, because you're also going inside the hospital, asking questions about, the toilet facilities, their functionality, etc. So it has some directives on that aspect, but of course, it doesn't have anything on the environmental discharge aspect. There, you are going into a different institution. That's the Department of Environment. And they have, of course, enforcement activities that can be applied to these hospitals. So now you're going into the domain of the Environmental Conservation Rules 2023 or Act, or the Medical Waste Management Rules, or etc. So those tools are, of course, there, and enforcement and those things can be also be linked here, because those are also absent to some degree, especially for private healthcare facilities or public healthcare facilities.
So I went through the regulations as well from the Bangladesh hospital wastewater discharge, and still there is only like POD, COD, and E. coli is not there actually as well as an indicator. So that's why I feel that we have to improve that, and this should be another recommendation in the systematic review, that the standard needs to be actually based on the pathogen contamination as well. But it will be challenging for low and middle income countries because of the laboratory facilities, but this is what we need to incorporate in the future.
In the new Environmental Conservation Rules 2023, it was published very recently, they have changed the wastewater discharge criteria. They have included E. coli now. That's the
that's
only one thing that you have right now. So from 1997 to 2023, we now have a new set of parameters, a few new sets. So E. coli will probably be addressed. So pathogens to some extent within that. So you can definitely mention that. Yeah.
Sure.
Thank you.
Thanks, Tanvir. That's great. Now, Tim, Juliet, any thoughts have come up in the interim?
So nothing further from me, Stu.
Yep.
No, I mean, I'm still thinking through what we've talked about the different waste streams, and just thinking back to different conversations we had in research design about, you know, Nuhu, we had talked about mapping out different waste flows and streams and grey water, etc., in the hospitals. And I think, yeah, I guess the actual realistic feasibility of that, became challenging. Yeah, all the pipes are buried in walls and nobody knows exactly what goes from what to what. And so, yeah, anyway, that's my memory of it. Yes, it's a little while ago since we were in that stage, but
yeah, I can comment on that. Like, we have planned about like liquid waste discharge mechanism, but once we enter into the hospital, I have lost everything, because it's almost impossible task to actually understand the mechanism, because
yeah, and it wasn't
behavior is very diverse over there. But one thing we can actually, if we can collaborate with the like local public work department, so actually they are the right person to actually provide all the map. And if they support us, because this was the collaboration with like Ministry of Health, like Director General of Health Service. But if you can collaborate with that ministry, and if that ministry supported us with the engineer, and we select one or two hospital, like new hospital, then it is possible to understand the liquid waste discharge mechanism. Particularly, for example, if we focus on Kurmitula General Hospital, which is very newly developed, we have to start with a good quality hospital with good service. Then we can use that model to the other hospitals. So that is one feasibility we can do, Juliet, to estimate the diverse liquid waste discharge mechanism.
Can I just add one perhaps potential suggestion? I don't know if this is my role, but suggestions to that is the qualitative component of that. Because, for example, sort of hospitals I've worked at elsewhere and things like the laboratory, they're doing cultures on kind of dangerously resistant organisms, and without being treated, they're just literally being poured into the toilet as the waste management. So it's not only kind of the piping and the infrastructure and what's flowing where, often it's the how these what's entering the system from either a human error or a practicality perspective at the point of disposal, because that's all there is. So just to highlight, there's kind of two components to that which might be of interest. The toilets might not only be being used for toilets, which your pictures indicated, but what the implications that has from sort of a pathogen or an infection prevention control perspective.
Well, thanks everyone. That's a lot of rich material. So now, Alison and Tanvir, you might not be aware that the next stage is we briefly asked Tim and Juliet to leave the virtual room so that Nuhu can raise any issues about his supervision in comfort and independence. So if that's all right, we'll proceed. So Tim and Juliet might go and get a cup of tea, and I'll text you, Juliet, to let you know when we're ready to come back. Or I might send you a Teams, actually, because I don't think, Tim, I realise I don't have your mobile number. So I'll send you both a Teams note.
I'll check
to say we're ready for you, and you can just
that's good.
We'll pop back on. All right.
Thanks very much. And so I've got Alison and Tanvir here. Thank you so much thank you again for agreeing to participate in the whole thing. But so Nuhu, this is just a chance for you to say how the supervision's going and any things you'd like to change or anything that's going well.
I think the supervision is going really well, because particularly Juliet and team provide me every week feedback. and we have a weekly meeting. I usually lead that meeting every week and every Monday Dhaka time in the morning and during the noon at the 11 a.m. Sydney time. We sit every week for the meeting and weekly update. So it's went really well last 2 years. At the same time, whenever I need, I definitely can reach Juliet and team as well. I know team is little bit busy with his kids, and he is little bit overwhelmed. I totally understand that, but his review is very crucial when I need any review in manuscript, particularly systematic review. And I also shared the manuscript one on the hospital sanitation infrastructure. So he will also very prompt on that. So I don't have any issue at this moment, and no change actually for this year. Right. And as you know, just I was also in Sydney for 3 months last couple of months ago, and we also have a lot of meeting with the modelers, other staff at UTS. So it's went very well still. Yeah.
Yeah, that's great. Thanks, Nehu. And great that you've had the opportunity to be here in person. That's really good for us as well. So I will invite them back using Teams. Just excuse me for, and let me see. For you. Great, and Alison and Tanvir, the next stage will be, as soon as we get Juliet and Tim back, we'll ask Nehu to step out while we sort of construct the assessment form and with the ideas we have for the future. But I might give you an opportunity, if you want, to get a cup of tea or have a short break. You might want some Spanish pastries there, Alison. I don't know if you've got time to duck out and get those, but for breakfast or something. But so we might just have a short break so we can stretch our legs. But I'll wait for them to come back so we can farewell Nehu briefly. I hope they got my message.
Yeah, team is joining. Yeah.
Oh, good. Welcome back, Tim. Welcome back. Welcome back, Juliet. And we thought we'd welcome you back before we said farewell briefly to Nehu. So there's a lot of logistics here. And then I thought we'd just have a 3, 4, 5 minute break, at least for Alison and Tanvir to stretch their legs and get a cup of tea if they need it before we then reconvene. But we'll leave Zoom on if that works for you, because you've had your cup of tea break. So, well, Nehu, thank you. We'll send you a quick Teams message if that's okay when to call you back in. I'm sure it won't be that long, but we'll give you a bell on Teams when we're ready to, and you can log back in. So thank you so much. That was really an excellent presentation. And
Thank you.
So
Thank you,
we'll see you soon. And everyone else, is that okay if we take a 3 or 4 minute break, and we'll see you back in the room. And you can talk among yourselves if you like. Juliet, Tim.
We should probably pause the recording too if we haven't, Juliet.
Yeah.
Actually, we should probably should have paused it before we.
Should have paused it before.
Should we stop?
I've just stopped it.